Okay, good morning, everybody. I'm going to do a really brief recap, as Katie said. So I'm really sorry because you all gave such wonderful presentations, and I'm not going to do them justice at all by just saying one line of what they were. But they were great. But it's just a refresher, just a reminder. So we started with Saul from ACF, obviously. He reminded us that we need to come up with an agenda to make sure that we keep this promise that we made 10, 15 years ago, whenever it was, for a scaled up quality public health intervention. So that was Saul's main point. Steve Collins then gave a very good talk to us. And he suggested that the current model of CMAM, while it's done very, very well, it needs to change to one of empowering communities to bolster demand, reducing opportunity costs, and ensuring real competition and transparency in local production. And that was a big theme of his talk. Then Andre Briand, a pensioner apparently, made... Exactly. Made some very useful points. The Lancet series and us and the nutrition sector, we're failing to assess the magnitude of the problem of wasting. Oh, I didn't put that in there, of wasting, because we're using prevalence measurements and not incidence, and we need to move towards a way of managing to measure incidence better. We also need to do more work on garnering, political will, getting that going, and we need to be less conservative, or it's going to take us till the 22nd century to get to where we want to be. Diane Holland from UNICEF then gave us an overview, and that the number of countries scaling up is continuing an upward trend, but the coverage is still quite low, and also that programmes are not happening enough in the development context. So then we moved on to session A, which was all about scale-up of SAM treatment. DFID gave us an overview of their experience in Malawi, Ethiopia, Kenya and India. And they've been trying to do much more innovative funding with this MYF multi-year funding, and that's becoming a bit more of a norm for them to try and prevent the stop-start programming and to bridge the humanitarian and development divide. But it reminded us that obviously there's no one size fits all for every context, and that there's an urgent need to dialogue with other donors, because the donors all have quite different ways of funding at the moment, and some are probably more constructive to CMAM scale up than others. Then ENN, my colleagues, gave a great presentation on donor financing. And the main points from that is, if we want to protect what we've achieved so far and to also increase coverage, which spoke to Diane's point of that, we might have masses of countries doing CMAM, but we haven't necessarily got great coverage yet. We need to move away from short-term and unpredictable financing towards much more government funding and funneled through government. So whether that be budget support, pooled funding, MYF, whatever it is. We need to position AM as acute malnutrition for Katie. We need to position acute malnutrition as a development concern, and we have an urgent need to review UN roles, the multiple UN roles and responsibilities around acute malnutrition. Then Sylvester, it was so lovely to hear your voice, from Malawi, the Ministry of Health and Concern, and 7 years of the CTC Advisory Service. And following an evaluation, it had overall a very good result. It helped with the standardisation of actors and protocols, and the operational plan for CMAM was costed. But there were still some challenges. It was still fairly parallel system, mechanism. The focus remained mostly at national level, and there was no national coverage assessment. So this is where the day then split into three. So we had 4 or 3 presentations in each of the 3 groups. So I'm afraid it really has gone down to one line to sum up your presentation. So the first session was treatment protocol and outcomes, and there were 3. MSF Spain in India, overall result that it is acceptable to discharge at greater than or equal to 120 millimetres MUAC. Valid international in Malawi. The main point was the earlier the admission into a programme, the quicker recovery. And MUAC greater than or equal to 125 millimetres is safe. And ACF Myanmar, good outcomes using an alternative, using less RUTF. if you combine it with other activities. Session C, which was the middle one, on performance. There were 4 presentations. I've got 2 slides going on here. CRS Sierra Leone used a 2-part referral booklet, to improve uptake from 69% to 93%. So they concluded that low-tech solutions work. And IMC Ethiopia presented that in 2 refugee camps, they used Wait for Height Z score to screen children with at-risk MUACs, and this resulted in improved coverage. Valid Nigeria conducted a retrospective study on defaulting, found that more than 50% defaulted after the first visit, and the majority defaulted while still in the critical condition. And World Vision Angola trained loads of CHAs, community health activists they were, in 4 provinces and got good coverage and good recovery. And then the session that I was in, so I can stop reading quite so much and feel a bit more confident about saying what went on, design and implementation. So there were 3 presentations in this group. ACF Nepal talked about the evolution of their IMAM approach. They worked with the Ministry of Health, but unfortunately the Ministry didn't make it. So they had 5 pilots, that scaled up to 11 out of a total of 70 districts in Nepal. And an important point is that there's a multi-sectoral national operational plan which is overseen by a high-level committee, and it reports directly into the Prime Minister's office. To the Prime Minister, I believe. And then UNICEF, I have to apologise, it was a 5-country evaluation and 1 line just can't do anything with that. So it was a range of findings of the 5 countries. Sorry. It was really interesting though. Do have a look at the presentation. No, Mark, there were some good results as well. And it is very interesting, so do look at it. ACF, from vertical to horizontal, and Anne-Dominique said, are we part of the problem? Which is a good point for discussion due to our habit of siloing, so putting in little boxes, nutrition, and our lack of understanding and engagement with the health sector. No, are we? All of us, you're included, Mark. And that's it. So, so that's it. Thank you.